I'd like to explore the question of what the role might be for immunotherapy combinations. We've established that drugs like pembrolizumab or Keytruda combined with chemotherapy uh, are a very good standard of care option, not the only one. Tecentriq or atezolizumab has also been compared with chemotherapy combinations, sometimes with the anti-angiogenic or blood vessel attacking drug Avastin. But there are also other immunotherapy drug classes, one called CTLA4 that works at a different part of the immune system than the ones that we've largely been concentrating on, drugs like Keytruda, Tecentriq, and Opdivo. There was a study called Checkmate 227 that's been out and reported in some forms for more than a year, but just had new data presented in the fall of 2019 that show that the combination of the drug Ipilimumab or Yervoy combined with Nivolumab or Opdivo, this Nivo-Ipi combination, is significantly better than chemotherapy alone for patients with PD-L1 detectable as well as PD-L1 undetectable. Interestingly, the results look particularly stronger in those with high PD-L1 or zero PD-L1, and not as good in the low PD-L1, which is frankly difficult to understand. But this is also a setting where chemotherapy is no longer our treatment of choice, and we've kind of moved on from that. And so because of that, I'm interested in your impressions of how attractive this combination of Nivo-Ipi is compared to what we already have, whether that would be Keytruda alone for the high PD-L1 group or commonly chemo with Keytruda for the negative or low. We like these combinations. They work. They're not hard to tolerate in general. I think there's an appeal to the concept of a chemo-free option, but this wasn't toxicity-free either. The side effects are pretty comparable to chemo, and they're just different. Mm-hmm. So, Millie, what do you see as the utility, presuming that we get an FDA approval for a two-drug combination of Nivo and Ipi or Opdivo and Yervoy? Mm-hmm. You've got this, you could use it, but we also have other options that have also shown a benefit compared to chemotherapy. So where's it fit in?
Agreed. I mean, I think this is where it gets confusing because there's no head-to-head comparisons here. So I think it will add to our treatment options. There are some patients who would want a chemotherapy-sparing regimen. So, I suppose it's nice to have this as a chemo-sparing regimen, although you point out that there are significant potential for toxicities, especially with that dual kind of PD-1 CTLA4 inhibition. We know that the rate of autoimmune toxicities is significantly higher. So I don't think there's an absolute right or wrong answer. I think
well, I was looking for the absolute
right, and so and I wish I could provide that, but yeah, I think this is just one of the. It's going to be another regimen that we can offer. And I think it depends on the specific patient. My tendency is to go with the chemo plus IO, and I prefer the platinum pemetrexed pembro regimen. It tends to be pretty well tolerated. It's relatively easy to administer. And so, and I think we've been using this regimen probably longer, than any of these other regimens that are, kind of more newly approved, or, in the case of Nivo-Ipi, it hasn't even been approved yet. And so I think time will tell. And, I'm not, certainly when we do get the FDA approval, I will probably use it. I don't know that it's necessarily better or worse.
Matt, who do you think where's the sweet spot for this? Where would you use this relative to the tools you already have?
Well, you used the word chemo sparing. I think there's also a case to be made it's chemo saving. Part of chemo and IO, Keytruda with carboplatin Alimta, very well tolerated, standard of care, better than chemo. But one of the problems with using that is the minute a patient progresses on that, what do you do next? You kind of go on to crappy second line chemo. And unfortunately, our next lines of therapy as of today aren't that robust. Taxotere is a tough chemo drug that doesn't work in a lot of patients.
Mm-hmm.
So there is some intuitive appeal to saying, if I can give a drug combination that clearly beats chemo in the first line, but lets me keep chemo for the second line, there's some appeal there. I think there's something to be said for that. I think it always has to come with a caveat that double immunotherapy is tougher. These drugs have been approved as a doublet in melanoma for a while now. Melanoma patients tend to be younger and fitter, and so we have to be really on the lookout for those kind of side effects.
It's not without risk in those people, of course, or in anybody.
Right, but I want to take a step back and say, for those patients who get single agent PD-1 or PD-L1 inhibition, some of them get their 2 years of treatment and are alive 5 years later. They never do see that next chemo. So if I can offer that immunotherapy alone, which just has that brass ring element, that maybe I can get that long-term response, I think there's a subset of patients where with a discussion, that double immunotherapy might be a really good first-line option. And then I always have chemo in my back pocket.
What about the question, there has been a suggestion looking at the data without any head-to-head comparison that the patients who get a two immunotherapy drug combo like Nivo-Ipi can have more sustained benefit. You have more patients who are alive without progression at 2 years. We don't have 3, 4, 5-year results, and we definitely don't have a comparison of Nivo-Ipi versus Keytruda alone in high PD-L1 or chemo Keytruda in everybody. But do you think that that angle has traction of maybe giving you the better chance of having the patient still doing well at 18 months, 2 years, or longer with an immunotherapy combo?
Yeah, I mean, I think that's where part of the appeal lies, and that's why I do think this is going to be something that we're going to be using, and patients may also be asking for it for that reason, and for the reason also of just not needing the chemotherapy up front and saving that potentially for later.
Because so far, I think the only patients we can reasonably give single-agent immunotherapy to, Keytruda, are really those 50% or higher. So we can go into the debate about the 1 to 49%ers. I don't do that. I think that data were flawed. That trial was flawed. But there, as you pointed out, there was this kind of subset analysis where the PD-L1 0% patients, where we don't think immunotherapy as a single agent works as well as other stuff, they did very well on this trial. It wasn't powered to look at those patients particularly, but there's something maybe in the mechanism where that dual checkpoint inhibition, maybe there's a there that even in those low inflamed tumors, those low PD-L1, who are they? But is there an opportunity to give them an immunotherapy only option, grab that brass ring, and again, maybe.
Well, it's interesting. I think if you really look at it, it suggests the people with negative PD-L1, they just do comparably well with Nivo-Ipi, whether they were high or low, but the chemo didn't do as well in these patients. So it's really the control arm that did disappointingly, which elevates the difference that makes it look so much better. But these are interesting, unanswerable questions. But I don't know if it's a blessing or a curse that Chinese race. May you live in interesting times. But we do. So thank you so much for spending the time.